Hello, everyone. How are you all? Welcome to First Aid AMC Clinical free 2-week session. I guess that you guys already know that this is the first class of our first 2-week session. And I guess that all of you has got the schedule for this first 2-week sessions, right? So tonight we are going to just revisit the MSE that we have done in our first trial session on psychiatry. Remember the 3rd August, it actually went very fast, right? So I remember like maybe just few days ago, we did that psychiatry MSc class, and just now we are starting this first free 2-week session already. So time is going so fast, as I can see. So this is Dr. Arshan, like previous, and most likely I will be your coordinator for the next 5 months for you who are joining the First Aid AMC Clinical 5 months course. So let's start. So tonight is solely based on how to do the role play actually, and it's a vital part to prepare for your exam. I can't say enough that how much important it is to know that the exact way to do role play, because it's all that you need to pass this exam. The more you do role play, the more confident you become and more better your approach becomes. So it's a vital part. And to obviously you can't do role play by yourself, you need one partner. So that's the next step that you should have. So all of you should have at least one study partner with whom you can do this role play. In our software, especially for those of you who have already joined the course, you guys already know that like in our software, there is a lot of questions already given there. You just need to open up one of the topic and then you start doing role play. Even some of the feedback is given there. Some of the, I can say like some of the answers are given there. So you can just read the questions and then you can read the feedback and you can make up your own case with your study buddy and then start doing role play. That's all that it takes. And as you can see by looking, if you are actually looking it in our First Aid AMC Clinical Facebook group, you can see that how many of you are passing the exam. And trust me, most of the candidate who actually is passing it from our course, they are all first time attempt candidate. And that's amazing, right? Previously, like I used to think, like me also, I was thinking when I was preparing for myself, I was thinking like it's really hard to pass this exam. But now you can see it's not impossible because in your eye, in front of you, you can see people are passing. And like in July exam, 6 candidates who appeared from our course, all of them passed. And that's really amazing. And that means that the approach that we are teaching, the guidance that we are giving to our candidates, that means it's absolutely right, right? That's why they are passing in their first attempt. And obviously, like we share their success and we're really happy that, well, it's not like that, like people are just going to the exam and they're failing, which doesn't make sense, right? If we make it, if we attend a course, that should give us that much idea to pass an exam. Nothing is impossible. If you are good, if your approach good, if you know like how to deal with the cases, if you are really good, obviously AMC has to pass you. There is no way. They don't fail someone who is not worthy. All right. So obviously it's a balance between your knowledge, your approach, and like as a whole, they want someone who is appropriate for Australian health system. So you just need to make yourself like that. So lots of babbling. So let's start our today's role play. I think we have started the recording also. That's good. All right. So who wants to do the first role play? So tonight we'll be doing role play based on the MSc and the psychosocial history that we have learned in our previous session. Okay, so who wants to start first? Dr. Nafisa, very good. So let me unmute you and then we can start. Those of you who are in the Facebook Live, I can see a lot of candidates, you guys are there. unfortunately, you will not be able to do role play because it's not possible to do role play from Zoom to Facebook. All right. So if you are eager to do role play, please come to the Zoom because that's only the way you can do the role play with us. So if you want to do role play, then come to the Zoom and then just write it in the chat box that you want to do role play tonight. And then if everything is good, we can start with you. Dr. Nafisa, can you hear me?
Yes, I can hear you. Can you hear me?
Yes, I can hear you. All right. 1 minute, Dr. Nafisa. I'll just stop this slide and then I'll start. I'll give you a case.
Okay.
Now for this case, you will get 7 minute 30 seconds in the outside and you will get 1 minute to read the case. Okay. So normally in exam, so you will get 2 minutes outside and 8 minutes inside to do the role play. Okay. But normally when you will prepare with your study buddies, always try to prepare 1 minute outside and 7 minute 30 seconds inside. Because previously when you were going for face-to-face, it took a lot of time to start the case. So people used to get like less than 7 minute 30 second in face-to-face exam. So if you are going for face-to-face exam, prepare in that way that 7 minute inside and 1 minute outside. But in the exam, obviously you will get 2 minutes outside to read the case and then 8 minutes inside. Okay. If you are going for online exam gives you exactly 8 minutes inside. Okay, so it doesn't kill any time. So in that case, you can just prepare as a 7 minute 30 second with your role, with your study partner. Okay, so let's just start. So this is your case, Dr. Nafisa. We'll start after 1 minute. Okay, so your patient name is David. You can start.
Okay. Hi, this is Dr. Nafisa, one of the doctors here.
Doctor, there is so much cockroach in front of you. Oh my God, what's happening in here? So much cockroaches.
Okay, David.
Yeah, it's on your shoulder. On your shoulder, there is a cockroach, doctor. Just, oh my God, it's so filthy room. Can you clean this room? I can't stay anymore. How this room can be so much filthy? It's just dustbin in here.
Okay, David, it must be very distressing for you that as there is so much cockroach. Don't worry, I'm gonna call the cleaner and he will clean all for you. Okay?
So filthy room.
Yeah, it must be very distressing.
Just go away. Leave me alone. Leave me alone. You stupid. Just leave me alone. Go. Oh my God. Hey, why these cockroaches are here?
Please, I can understand you are going through a hard time. It's really filthy. I can understand. I have already called the cleaner. They are on the way. Okay, so please try to bear with me. I can understand you have gone through a surgery. So do you have any pain right now?
No, I don't have any pain, doctor, but this
Mhm,
cockroach is making me. What's
mhm.
happening in here? Why there is no
Okay.
one in here? Where is the
He
cleaner? There's
Yes,
no
he
one.
is on the way. He is on the way. He's coming. So in the meantime, can I ask you some questions? Don't worry. Whatever we will discuss, it will remain confidential between you and me. Is that all right?
Yeah, whatever. I just want this room to be clean. That's all.
Yeah, I can understand. I have already called them. They are on the way. They are coming as soon as possible. Okay. So can you please tell me, how is your mood nowadays?
Yeah, it's okay, but this cockroach is making me so stupid cockroaches. Just go away from, just leave me.
Okay. Okay. So anytime do you feel low or high?
Oh, why I would feel low, but this cockroach is making me look like feeling like
Yeah.
I want to just all this stupid box.
Okay, okay. So, where are you seeing these cockroaches? Is it everywhere?
It's all over the room, doctor. It's one is just on your shoulder, doctor. Just it's
Mhm.
on your shoulder. My
Yeah,
God,
okay.
it's all over the table.
So, how is your sleep and appetite nowadays?
Yeah, it's okay, I guess.
Okay. So, you have told me that you are seeing the cockroaches, right? So, can you feel the cockroaches?
It's all over my body, doctor. It's crawling inside. It's crawling
Mhm.
on my everywhere. Oh my God.
Okay. Okay. So, you can feel it, okay? Right?
Yes, obviously, there is cockroaches going up and down all over
Mhm.
the.
I'm really sorry. I'm really sorry, David. Please try to bear with me. They are on the way. The cleaners are on the way. Okay. So, do you think that you can hear or listen anything that another can't?
No, what do you think? Do you think I'm a crazy person?
No, no. It's just a screening question. I'm just asking. So, do you think anyone is trying to harm you?
No,
Okay. Do you think anyone is trying to control you?
no. Who's going to control me? Oh my God.
Okay. Okay. So, do you think anyone is trying to put any thoughts inside you or trying to withdraw any thoughts from you?
No,
Okay. So, do you think that your thoughts are broadcasting in the television or in the radio?
no.
Okay. So, do you think that do you ever think that life is not worth living?
Why I would think so?
Okay, good. So, have you tried to harm yourself or others?
No, but I just want to kill this box. Oh my God, there is one on the table, just beside you. Just to kill that
I'm
stupid
really
box.
sorry, David. Yes, I'm really sorry. I don't know why they are doing late. They are coming. Okay. So can you please tell me that do you think if there is any fire in this room, what will you do?
Is there fire in this room? Oh my God,
If
where
you
is the
see,
fire?
no, no, if there will be any fire, what will you do?
Yeah. I don't know what I will do. Is there fire?
No, I will just say you to think if there is any fire, what will you do? That's the thing. Okay, there is no fire.
Yeah, I should. I will run. I will run
Oh,
away.
okay, okay. So do you know who am I and where is this place?
Yeah, I know this is a filthy room filled with all cockroaches.
Okay.
You
Oh, okay. So, have you ever tried to take any medications on recently, or any drug, or any illicit drugs?
No. I had the surgery, doctor.
Okay. So, have you ever hurt your head, or do you have any changes of weather preferences nowadays?
No.
Okay, okay. Thank you so much for all the informations, David. So, dear examiner, I want to present the mental state examination of my patient David, who is a 47 years old patient who had surgery recently. Uh, According to his appearance and his behavior, I would say he is organized. He's dressed according to the weather, but he is quite unkempt. According to his speech, I will say his volume rate is normal, but it is quite disoriented because he was interrupted by some cockroaches that he can see. I would say he mentioned that his mood is all right, but the effect which I can observe, that is that is disturbed. So I would say it is not congruent to his mood. He has visual and tactile hallucination, and in thought form, I would say it is linear. He was answering all of my questions, but his thought content was there was no there was no delusion, but there was active hallucination, and his insight is not intact. His judgment is fine. He is oriented with time and place, but I would say he has high risk of because he has active hallucination, and he can active hallucination. Yes, that's why I can say. Thank you so much. Sorry, Dr.
Thank you, Dr. Nafisa. You did really good. That's fine. I would say like you did really, really good, because like these sort of cages, people used to get like disoriented, like the examinee or candidates get disoriented because the role player, like I can say that the role player in the exam will be like much more better actor than what I was. So they are really, really good in making you like kind of like disturbed during the exam. So some of the candidates even totally forget the psychiatric assessment, like the aseptic J3R, because of the pressure the role player put on the candidates. But you did really good. You were calm and confident. That was the most important part in here.
Thank you.
So the initial starting was pretty good, that you asked about the surgery, you asked about the pain, and okay, that was really good. You did the confidentiality statement, that was really important. And then you started asking about the mood, sleep, appetite. You asked about hallucination, delusion. You missed insight, but you told it that it was not intact during your MSc presentation. It's important that if you forget something to assess, just say that you could not assess it, or you forget to assess it. And that's something they really, really like. Okay, that if you did not assess something, but you say that you assessed, that means that they don't actually like this thing. So it's very important, like it's very okay that you can miss just one part. And that if you just say that I forgot to assess that, they will be happy. Okay, they will not fail you for that.
Okay.
So just say that I forget about it, that's fine. And in judgment was good. In this case, one thing that you could add in your MSc presentation, that this patient had a concrete thinking. Why? That when you say that, what do you do if there is a fire in this room? I say that is there fire in this room? This is called concrete thinking. Patients who are having this active delirium or schizophrenia like symptoms, they have this concrete thinking. That means they don't understand the thing that you actually asked. Like you asked a question that if there is a fire in this room, what you are going to do? But because their thinking level is not that much good, they have thought disorder or poverty of thought, they show sort of concrete thinking. So you can say that in your thought content. Like when you say that thought content is linear, you can just add that this patient also showed some concrete thinking, because when I asked about the judgment questions, patient was saying something like that. Okay, so just you can add that in here.
Okay.
And it's not very vital. If you even miss that part, they will not bother with that, but you can add this one. Then cognition was intact in here. Then you have 3R, right? This patient is obviously high risk because of active hallucination. And you were able to maintain a good rapport. And this patient's history is not reliable. So reliability is not good. So you have to take a collateral history from anyone else. Like in this case, collateral history would be better to take from, let's say, from the relatives, or most likely a relative would be a good idea. Like if anyone is here with him, so we can take a collateral history from them. One of the important part in this case that the diagnosis, most likely it's a alcohol withdrawal, because if you look at here, patient has a long history of alcohol intake, and you have to ask it in your psychiatric assessment. You have to ask this part, like, do you smoke or drink alcohol? Patient might say like, yes, doctor, I used to drink alcohol. So you need to say, when was the last time you drink alcohol and how much normally you drink in a day? So this way you will know that this patient is actually a chronic alcoholic, and he could not drink alcohol because he's in the hospital. So that's why this patient develops this delirium. All right, so it's a delirium induced by alcohol withdrawal. That's the diagnosis. Sometimes they even ask diagnosis in this case, so you should know about it. So if you don't ask that question, you will miss the diagnosis. Okay. And I guess everything is good. So appearance in this role play session, you guys, like for all of you, just in the appearance, you can say anything because you can't see me. So it's very hard to say what's the appearance. So just give anything what you want, that's fine. But in the exam, appearance has some point. So like in the appearance, we talk about how the patient is dressed. Is it unkempt or well-groomed? We talk about eye contact. We talk about any inappropriate behavior. We talk about abnormal posture. So all these things we need to add in the appearance. You talked about his speech. It was good. Emotion, you said disturbed. Affect, that was right. Yes, this patient having auditory and tactile hallucination. Sorry, it's a visual and tactile hallucination, no auditory hallucination. Thought form was linear, and thought content, patient did not have any delusion, that's right. Insight was not assessed. Judgment cognition was right. And 3R we just discussed. Okay. So pretty much you discussed everything, and the way that you said, it's very good that, well, the cleaner is on the way. So please don't get stressed. I'm giving calls so that he comes here and to clean up the room. Okay, so always start in that way. Try to calm him down, reassure that you are calling the cleaner to clean the room, give the confidentiality statement. And some of the candidates start with the cockroach and then they move to the mood and all other questions. If you guys feel like you will not be able to remember, then you can start the mood and then just follow the approach. That's also okay. All right. So thank you, Dr. Nafisa.
Thank you. Thank you, Doctor.
So we'll just go through this case very quickly. So in this case, obviously you have to introduce with the patient, and you will see when you go into the room, patient might be like hitting the cockroaches or being very aggressive, like why there are the cockroaches, it's a very filthy room, something like that. So try to calm him down, say that, John, I'm really sorry that there are cockroaches in this room, but I'm now calling the cleaner to clean this room. Okay, so cleaner will be here within few moments. In the meantime, I would like to ask you some questions, and I want you to know that I will be here with you until the cleaner comes to clean this room. And also, whatever we are going to discuss in the moment, that will be confidential between you and me. Now, John, as I understand that you had a surgery about 24 hours ago, do you have any pain in your surgical site? No, doctor, I'm fine. So that's really good to know, John. John, would you please tell me a little bit more about your mood? Okay, so then you asked about mood, sleep, appetite. You can ask about suicidal ideation question. All right. Now, today we are not going into those questionnaires because we discussed that fully in our previous class, like all the questions. So today we are not going into those questionnaires again. So just going through that very quickly. So you need to talk about mood, sleep, appetite, suicidal ideation question. And then you can see that when Dr. Nafisa was asking me that do you see or feel something that others don't? I told that, do you think I'm a crazy person? To avoid this sort of confrontation, it's a good idea to say that, John, I'm going to ask you some sensitive or screening question that might seem a little silly to you. Is that okay if I ask it to you? These are just screening questions. So then you ask the hallucination delusion questions, and then patient will not bother with that. Okay. In that case, patient was hitting the cockroach. You can always ask them, I can see that you're talking about the cockroaches. Can you exactly say where are they? Okay. Can you feel the crawling? Can you feel the cockroaches on your body? Are they crawling? Okay. Can you, like, where do you exactly see them? Do you hear any voices? So just make sure you ask all the hallucination question. Then you go to the delusion RC GTP question, ask about thought insertion, thought withdrawal, and broadcasting. So all these questions we have to ask here. Okay. Then inside cognition and judgment question, followed by just the heads question. Because it's a psychiatric assessment, if you go through the question, it says perform a psychiatric assessment. So in that case, if you think that your time is still, you have some time, then go to the heads. So ask about who do you live with, what's your occupation, okay? Ask about SADMA, ask about past mental history, family history. Now, if you think that you are running out of time, then don't bother with all these questions. Make sure you present the MSE to the examiner first, because your MSE doesn't bother with heads or SADMA. Okay, so that's a very important thing. Clear, guys? Any question you are having? Yes, Dr. Sheher, that's right. So in this case, if you want to ask about insight, you have to ask that, do you think you need any medical help? If patient has insight, and they will say, yes, I need some help. Most of the schizophrenia or psychotic patient will say, no, I don't need any help. Alcohol withdrawal and delirium tremens are not same, because delirium tremens is the highest or the most dangerous form of alcohol withdrawal. Okay, Dr. Shoaib. So alcohol withdrawal can present with just some kind of, sometimes let's say that irritability, anxiety, insomnia, okay, those are, and also some kind of craving for drinking alcohol. But when it becomes delirium tremens, the name is delirium tremens. So tremens means there will be some tremor, and the delirium means acute confusion. So patient will have these like confused things, disorientation will be there. Patient will be having this visual hallucination. This is very common. And most importantly, if you check the vitals of a patient of delirium tremens, you will find hypertension, tachycardia, patient will be sweaty. So autonomic hyperactivity is a very important component of delirium tremens. So that should be there in that case. Yes. Now, even if in this case, we have to ask all the questions. Even if patient seems to be psychotic, you have to ask those questions just to be aware. Some of the patient, they like psychotic patient means that they don't know anything and everything they say is wrong. It's not like that. Some patient knows that where they live. Like even a fully disoriented patient, like not disoriented, I would say fully psychotic patient, they sometimes they can answer a little bit. Like, yes, my mother told me that I had schizophrenia. So very vital and like vital questions and answer you have got it. So whatever it is, ask those questions. Head SADMA, just ask it as a format. Most like if the patient is not giving appropriate answer, don't bother, just move on to the next question. Okay, Dr. Sachi. Those who are in the Facebook, do you guys have any question? So Dr. Priyanka, how much time you will be given in online exam is the same online and face-to-face. You will be given 2 minutes outside. That means to read the task before starting the case. So 2 minutes to read the case and 8 minutes for your performance. Cool. Who wants to do the next? Dr. Sharkar? Okay. Let me unmute you. Now, many of you might be here who hasn't done our first session on MSE. You might think like we are going very fast. And for those of you, I would suggest to finish the first class first, okay? Because that was the baseline of our today's session. So if you don't do that class, you will not even understand what I'm talking about. Yes, Dr. Nidhi, that's available in the Facebook group also. If you just write the recording in the search option, then you can easily find it out. And also, if you just go through our first aid AMC clinical group, scroll it down, you should be able to find out the recording. The very easy way to find out the recording is go to the search option in that group, first aid AMC clinical, and in the search option, write recording. And all the recordings of the trial classes will come there. Dr. Sharkar, can you hear me?
Hello, doctor. Yes, I can hear you. How are you?
Yeah, I'm fine. How are you?
I'm fine. Thank you.
Okay. So I'll give you the case. Just give me 1 minute.
Okay.
Okay. Give you this case. We haven't started the screen yet, so we'll start the screen now. So this is your case, Dr. Sharkar. You'll get 1 minute outside and then we'll start.
Yes.
Okay, so this patient name is John. You can start.
Hi, I'm Dolan. I'm the one of the doctor here today. May I know your name, please?
I'm David.
Hi, David. So how are you doing today, David?
Yeah, I'm good, doctor. It's just the police brought me here. I don't know why. I'm fine. I don't need to be in hospital. I don't know. I was doing very good. But I don't know why police is so bothered. Can I go?
Look, David, I need to ask you some questions. So after that, we can see that you can go home or not. Is that all right if I ask you some question in this conversation? Whatever we're gonna discuss, it will be remaining confidential between you and me, unless it's harmful to you or others. Okay?
Yeah, whatever. Everyone wants to ask questions. You know, like since I stepped into this emergency department,
Mhm.
about
Mhm.
people ask me questions, and all of them say that they're going to just send me after asking some questions. What is this bullshit is going on? I don't know.
Oh, I can really understand that it's really disturbing for you. So, John, how's your mood nowadays?
Yeah, yeah. I'm feeling all right, doctor.
Okay. And what about, so in this conversation, I would also like to ask you some sensitive question, but I ask some of my patients to get to their bottom of their condition. So do you feel low or high sometime?
No, I feel all right all the time.
Do you have any thoughts of harming yourself or any other?
No, doctor. I just live in the street and I just roam around. I live my own life. I don't want to do any harm to anyone.
No. And what about if you can see, feel, or hear things which others don't?
Mm, No, why I would do that. But I want to talk to you about one thing, doctor. It's really
Mhm.
disturbing me for a couple of months. I can
Mhm.
hear some mumbling voices. I think like
Okay.
someone from the other world. They're trying to reach me for like they're trying to say
Mhm.
something about
Mhm.
about this destruction of this world. I think, but they
Mhm.
can't reach me really. So they're trying
Mhm.
to build some connection between my mind and theirs. But
Mhm.
I can't actually understand what they're saying. But I
Mhm.
understand that they're trying to say something about this end of the world.
Okay. Okay. And you can see them?
No, they just can't come up. I asked them that if you want to tell something, just come in front of me, but they're not coming.
Mhm. Okay. Okay. And do you think you have a special power?
No, I'm just ordinary person.
Okay. And do you think and anyone trying to insert thoughts in your mind or try to withdraw thoughts from your mind?
I think those people are trying to like they understand what I'm saying, what I'm thinking. Sometimes they can even I can feel like they know what I'm thinking. I don't know why how they do that.
Hmm. Hmm. Okay. And what about anyone trying to harm you or spying on you? Is there any, do you feel like that?
No,
Okay. And tell me about how's your sleep nowadays? Any change recent?
no,
Okay. And any suicidal ideation?
no,
Do you think you need professional help?
no. I say, doctor, I'm feeling perfectly fine. I just don't know why these police are bothered. They just like, I don't know, like I think they have some problem. You should talk to
Yeah,
them.
I can understand that. As I told you, there's all our screening questions, so that's why asking. Do you think that if there is any fire in this room, what will you do?
Nothing. I don't know. I know there cannot be fire in Zoom. I can't see any fire. I'll just
Can you?
stay, I think.
Yeah. Okay. Okay. And do you know where are you and who am I?
Yeah, yeah, you're the doctor. I'm in the hospital.
And what time of the day now?
Doctor, I don't have the watch. I'm not totally
Mm.
sure.
Okay. Who do you live with, John?
I live in the streets, doctor.
Okay. And in you have any okay, and do you have support and any financial problem?
No, I don't need any help. I'm fine. I'm doing very good. I don't need any support.
Okay. Do you have any past medical or surgical history I should aware of?
My mother once told me that I had some schizophrenia, I think, something like that.
Are you taking any medication for that?
No, I used to, like a couple of months ago, maybe 6 or 18 months ago. I can't remember, but I don't want any medication. I'm feeling fine. So why I would need any medication?
Yeah. Okay. Okay, I can understand. And yeah, any family history of no, thank you. Thank you, John, for your history. I forgot to ask you about your or any that I can see an ulcer in your right foot. Can you tell me, do you need any painkiller for that, or how did that happen?
That's okay, doctor. Don't bother with that. It's been there for a long time.
Okay. Thank you for your history, John. I would like to talk with my examiner. Examiner, I want to present my mental state examination of my patient named John, who is 40 years old, brought by police because he was wandering in the street. He is a known patient case of schizophrenia, and he is not using any medication right now. And his appearance is quite unkept, and he's not wearing dress up according to weather. His body posture I cannot see right now, and he's cooperative with me, and he's also maintaining eye contact, and his speech is normal, and according to him is the mood is normal, and affect I can understand, which is congruent with his mood, and he's having some perception of auditory hallucination, and he's thought no other hallucination, and his thought form is and ideas of reference I can see, and his thought content is no thought content, no delusion of paranoid, delusion of grandiosity,
Time
and
up, but you can continue.
and his cognition, he's well aware of who am I, and time and place and person, and his judgment is good right now. His judgment insight is good, and insight is poor, and judgment is good, and he's a risk of some he's in risk because he is having some auditory hallucination, and I'm thinking that he's been in risk, and I built a rapport, but I need some collateral history from the police or the nurse or doctor who attending him before me. Thank you, doctor.
Thank you. All right. It was really good, Dr. Dr. Sharkar. Is your name Dr. Dolan or Sharkar?
Yes, my name is Dolan Sharkar.
Dolan. Okay, I'll just say Dolan. So Dr. Dolan, it was really good, I would say. And you asked most of the important questions, and the way you dealt with this with this role player, it was really good, I would say. And yes, you did the confidentiality statement, but the initial thing that I would say in here to do it at first, that means this ulcer, you did it at the end, good to start in this way, because someone having an ulcer, always we built rapport in that way. Like we show to the patient that we actually care for them. Even though it's a psychotic patient, that patient has a sense, right? So you should always give them those sense of well-being that, yes, this doctor take care of me. So it's very important. Even though they are not too much bothered with that, it's still just start in that way. Say that, hi, John, this is Dr. Dolan, one of the doctor in this hospital. I understand that you are here because the police brought you here because you have been wandering in the street. How are you feeling today? So just start in a way like, how are you feeling today? Just when you say something like that, the patient will say, yes, doctor, I don't know like why the police has brought me here. I'm totally fine. Just let me go. Then you give your confidential statement and say that, John, I'm really sorry that you're feeling in that way. And you must be really stressed because police has brought you here. But let me ask you a few questions. And then if everything is good, I can assure you, I will let you go. But in the moment, I also want you to know that whatever we are going to discuss, it's going to be confidential. You can talk to me about anything. You don't need to feel ashamed. You don't need to feel just about anything else.
Mm.
And I can see that you have an ulcer in your right foot. It must be really, really stressful or really bothering for you. Do you want me to clean that, or is it painful? Do you want me to give any painkiller for it? So just start in that way, like you take care of that ulcer. Patient in here, they will say, no, doctor, I don't bother with that. When they say don't bother with that, don't go in detail about the ulcer. This case is not about the ulcer, it's about MSE. So then you will move to the mood, sleep, appetite, suicidal ideation question. Then you ask hallucination, delusion, all those questions. Now, after you have done hallucination, delusion, insight, cognition, judgment, we go for heads. You ask about who do you live with, financial problems, and everything you ask actually. Ask about SADMA. Don't forget about,
Yes.
because sometimes it could be a drug-induced psychosis. We don't know that. So a very good idea to ask about any alcohol, any smoking, and any recreational drugs. Okay. And followed by that, you can ask about past history, past mental history, family history, mental illness. That's pretty much everything about the history. In the MSc presentation, appearance, you cannot talk about it, that's fine. Always say, like, always give this MSc finding exactly according to the format. So in the speech, yes, in the speech, you will say that the speech was normal in tone, volume, and rate. These words, little words, actually, it shows to the examiner that you know these things pretty well. So if you just say that speech is normal, that means that maybe like you don't know the full things. Okay, so always use the full term, like speech is normal in tone, volume, and rate. And all of you, I would say, like, try to finish this history pretty quickly so that in the MSc, you will get exact time. I was actually supposed to give you a prompt in 6 minutes, but it's my mistake that I forgot about it. So, but normally, if it's written in the exam that history no more than 6 minutes, in the 6 minute time, you will get a prompt that your 6 minutes is up. Okay. In that time, always in the MSc presentation, you need at least 2 minutes. Okay. Otherwise, it will not be full or complete. So it's a good idea always to say some negative findings also. So say that this, like his speech was normal in tone, volume, and rate, but there was no disorganized speech. There was no rapid pressure speech. It means that you really, really know these things very, very good, because that means you have been looking for this. Okay. So it's a good idea to say some negative findings if you have the time. If you don't have the time, don't bother with that. So emotion was all right according to the patient. Always try to say exact word patient says when you say, how is your mood? Sometimes patients say okay, sometimes patients say normal, sometimes patients say all right. I said all right. So you say exactly what I say. So according to the patient, mood was all right, but the affect that I have observed, it was not congruent with the mood. Usually affects for psychotic patients, affects are not all right. Okay, this patient, does it seem like his mood is all right? No, it seems kind of disturbed to me. So it's a good idea. You can say that patient's affect was not congruent with the mood, or a good idea to say that affect was disturbed, according to me. Okay, then after emotion, then you have perception. This patient had auditory hallucination. Say that there was no tactile or visual hallucination and no command hallucination. When you say command hallucination, any patient having auditory hallucination, if you find it in your questionnaire, you should ask them that, do you think that they are commanding you to do something, John? So it's a very important thing, because sometimes these auditory hallucination give command, that they give command to kill someone. And that's very important to find out that if there is any command hallucination or not. Okay. So in the perception, we say that this patient had, in terms of perception, he had auditory hallucination. There was no command hallucination, visual or tactile hallucination. Then thought form was linear. There was no tangentiality or circumstantiality, no loosening of association, no flight of ideas. Then in terms of thought content, this patient had delusion, but there was no paranoid delusion, no delusion of control, no delusion of grandiosity or guilt. But what this patient had is that when you say that, do you think that there is someone is inserting or withdrawing thought from your mind? I say that, I don't know, doctor. Whenever I feel like they know everything what I am thinking. What does it mean? It means that the thought is getting withdrawal, right? So this patient is actually having thought withdrawal. They will not exactly say whatever you want to know to understand that what actually they're trying to give it to you. Okay. So I was trying to give it to you, yes, my thought is getting withdrawal from my mind.
Yeah.
So only that was positive in here. That's why in schizophrenia patient, it's very important to ask all the delusion questions because we don't know which one will be positive. Okay. So you did good, actually. You asked the question, but unfortunately you forgot to interpret that. But that's okay. You will find it later on. Okay. So there was no idea of reference, as you said. The idea of reference, or mainly delusion of reference, means that everyone is commenting what I am doing. Everyone, the people are talking about me in the street. That means that they are referring me. If I think that someone in the street is always talking about me, or everything is actually referring to me. The comment they are doing, it's referred to me. Everything is just about me. That means I'm having delusion of reference. So this patient only had thought withdrawal, nothing else. Then we have insight was poor in here. Judgment was poor. You said good, but judgment was not good in here because I say that I will stay here. There was some concrete thinking also, but that's fine. But the judgment was not good in here. Then what else? Cognition was okay, but the time patient was not actually oriented because he did not have the watch. That's fine. And risk, this patient is a high risk, obviously. Then yes, you were able to maintain a good rapport with the patient. And reliability, this is not reliable. So you did really good, I would say, Dr. Dolan, but just a couple of things which we need to improve. But as a whole, you did really perfect.
I wanted to ask about this answer at the beginning, but I forgot actually. I started with the MSc questions.
Yeah, that's fine. I understand that. That's okay. But as long as you will do it right in the exam, remember, if something is given like this in the exam, the approach should be started with this. Like anyone having pain, we always give painkiller first. That's actually gives you 4 in the approach immediately. Okay, so very important.
Thank you, doctor.
So this idea of reference and delusion of reference, it's a like very tiny difference are there, Dr. Shihar, in between these things. But if you get a schizophrenia patient, don't use the term idea of reference. Idea of reference is actually, you will have some kind of like people will refer to you, but it's based on some real event. Okay, sometimes it's just a precursor to the delusion of reference. That means this patient start with the idea of reference. That means some patients say that I feel funny. Okay, so this feeling funny is like something is funny going around me. There's something going funny around me. Patient actually doesn't know what's actually funny. This is actually a precursor to the full-blown delusion of reference. So they say that idea of reference based on some real events, and delusion of reference is like it's a bizarre thinking that patient actually shows. Okay, is there any other question, guys?
Doctor, can I ask a question?
Yeah.
How to end the MSc presentation, like after the reliability, risk, and report? What I need to say?
Just finish in the reliability questions. So you don't need to say any diagnosis or anything unless it is asked. The MSc presentation finished with 3R. That means risk, reliability, and rapport. Once you finish that, you just thank the examiner.
Okay. Okay, thank you.
And also, Dr. Sheher, like one of the very good difference between idea of reference and delusion of reference, the content is pretty much same, the thinking that people are talking about them. But in idea of reference, if you challenge that person that no, they are not actually talking about you, patient will actually say, yes, maybe they are not talking about me. So you can change their mind. But in delusion of reference, they're having a very concrete belief that even if you challenge them, if you show them, no, no, these people are not talking about you, they will not believe you. Their belief will not be changed. So that's actually the main difference between these two. So if patient repeatedly say, why police bring me here, then what would you say? You can't say that you are ill or you are having some problem, that's why police brought you here. So you always give answer in a way that doesn't confront the patient and also calm down the patient. Say that, always say sorry, because it's not your fault that police bring that patient to you. But again, it doesn't cost anything to say sorry. So say that, John, I'm really sorry that police brought you here today. But don't worry, once I finish asking you all the questions, you will be able to go home if everything is fine. So just now I want to ask you a few questions, and then I can talk with the police that, well, you are totally fine and you can go home. So that's why I need to ask questions. And I want you to know that whatever we are going to discuss today is going to be confidential. See that now what you did, you tackled a very important thing, and now patient will think, well, this does make sense. Okay, so that's important. Always take the side of the patient. No, they will not give you malingering patient. I haven't seen any time there is any malingering case. Okay, usually always the actual psychiatric case comes in the exam. In online exam, Dr. Aziza Malik, it's not online exam, it's both online. That means for AMC clinical exam, you have to pass 10 out of 14 stations. Don't ask in that way, Dr. Grace, that do you feel like people are commenting about your behavior? Say that, like you can say that, do you think people are talking about you? That's a good question. All right, like to find out idea of reference. We actually described those RCGGP delusion questions in our previous class. So if you say in that way, like, do you think people are commenting on you all the time? That's also a question for delusion of reference. Now, we don't need to go in detail in that way that it's an idea of reference or delusion of reference. So next question you ask that, well, do you strongly believe it? It's not needed. Actually, it will just take your time. If someone having all the features of schizophrenia, usually it should not be an idea of reference. It should be a delusion of reference. So for psychiatry theory, you don't need to read from anywhere. You just follow our first class on psychosocial history. That should be fine. Okay, because we described most of the important things and findings that you can get in the exam. All right, any other question? We'll start with the next case. Who wants to do the next one? Okay, Dr. Wafi and Dr. Sheher, we can start with you at the end. Do we need to read Tally O'Connor? No. Tally O'Connor is mainly for physical exam, Dr. Neetu. So you can read it, but the physical examination class that we take, that's absolutely what you need for the exam. But if you need to learn a little bit more, if you are having any difficulty understanding any particular topic, you can always read it. It's not mandatory. So Dr. Wafi, I will just start with you. I'll unmute you now. And Dr. Sava, we told about the difference between idea of reference and delusion of reference. What is actually this delusion of reference? It means that if I think that people are always commenting on my behavior, people are, whatever they are saying, they're actually talking about me. That means I'm having either idea of reference or delusion of reference. Now, to differentiate between these two, there is like a very tiny difference, and we don't need to worry about it in the exam. That's the one thing. That's why I told that don't go in too much detail in clinical exam. Clinical exam doesn't need to be absolutely perfect. Like, is this patient having ideas of reference or delusion of reference? Both of them are kind of same. The thing is same. The only difference they have is that in this case, if it is a ideas of reference, if you confront the patient that no, I think that they are not commenting about your behavior. Okay, if you confront them, if you challenge them, then they will say, yeah, you are right. Maybe they are not talking about me. Okay, but in that means their belief is not that much strong. But in case of deletion of reference, even if you challenge them, even if you show them no, they are not talking about you, even if you bring that person in front of that patient and that person say, no, I'm not commenting on your behavior, still they will not change their abnormal belief. So they have a strong belief and that becomes deletion of reference. If you are unable to finish history on time, like let's say your 6 minutes is up, then stop the history and then start saying the MSE finding. That's why it's very important, Dr. Alice, you need to finish at least the important aseptic J3R in time. Okay, otherwise you will not be able to pass. That's actually a frankly talking that if it means that in this exam you have to finish it in time. That's important. So if you think that 6 minute prompt is up and only thing that is left is heads, SADMA, past medical history, then you just stop there, thank the patient and go to the examiner to present the MSc. But if your time is up and if still you haven't asked delusion question, then there is no way you will pass, right? Because you will just miss the important aspect of MSc presentation. There is a time clock. Obviously, they will always give you a prompt in time. So not every questions get prompt. It depends. If in the history it is written that history no more than 4 minutes, then in the 4-minute time you will get a prompt. If it is not written in your task, you will not get a prompt. You will only get a prompt at the end of the 8-minute. Okay. And Dr. Josh, there is no such consensus that how many psychiatry stations will be there in the exam, but not more than 2. I haven't seen more than 2 psychiatry cases in any exam. Okay, let's just start. We can answer these questions at the end of this class, guys. Okay, I would really prefer that if it is not related to the MSc, ask these questions at the end so that we can do more cases and that will help. Okay. So who wants to do the next one? Dr. Wafi. Dr. Wafi, can you hear me? No, I think. I have unmuted you. Let's see if you can hear now.
Yes, I can hear you now. Hi, Dr. Ashan. How are you?
Good. I'm fine. Thank you. How are you?
Oh, not too bad.
Okay. All right. So, I'll give you the case. Just hang on a minute. Okay, so that's your case. We'll get 1 minute time and then we'll start. All right, so you'll get 7 minute 30 second for this case.
Yeah.
And the diagnosis and differential, you have to give it to the patient, okay?
Okay.
Patient name is Sarah. You can start.
Hi, Sarah. I'm Dr. Wafi, one of the doctors here today. How are you today?
Oh, doctor, I'm really fine. You know, like I'm feeling absolutely good these days. And you know, like these counselors in the university, they are absolutely rubbish. They don't know what they're talking about. I'm feeling so good for a couple of weeks, and this is the best time in my life. And still, like this counselor just sent me to you. I don't know, like why I'm just wasting your time. I have a lot of things in my head at the moment. Like I just can't waste any time. You know, like there's a lot of things going on, and I'm thinking like to get some Nobel Prize on biophysics and all these molecules and atoms, how they work. And I'm trying on like lots of theories, and no one actually knew these things. Just like it just came up in my mind yesterday night, and I don't need to even sleep or feeling so good for these days.
I'm sorry, I just have to stop you there for a bit. So I'm just going to ask about like recently about your university. How is your studies going at university?
Just those are just bullshit, doctor. These are only crafts. These are given for the students just to keep them in the university. You know that they don't actually teach anything. The real thing actually is known by me, and I can teach those students. Those counselors, universities, they don't know anything. They are just jealous about my success, and they know that I'm going to get that Nobel Prize very soon.
And so, how long have you been feeling really good for?
2 weeks, I think.
Okay. Anytime we've also felt a bit depressed as well, or have you always felt good?
No, normally I feel I feel normally all right, but this time is really good. And I have lots of energy in myself. I usually used to just sleep and doing nothing, watching some televisions, but now I feel the real purpose of my life.
Okay. All right. And have you had any loss of weight, loss of appetite?
No.
Okay. Do you still enjoy the things you used to?
Yeah, I'm enjoying a lot of things at the moment. Like I enroll myself in the swimming. I enroll myself in the yoga these days, and also like I think like I have to also enroll myself in one of the online course as well. It's so good, and yeah.
Sorry, Sarah. I'm just like to say, okay. As I'm asking questions, I'd just like to again tell you that everything we discuss will be confidential unless there's a harm to you to others. Okay.
Okay.
Yes. Okay, Sarah. So now, recently you said, have you noticed any weight loss or weight gain?
No.
No. Okay. All right. How about your appetite?
Yeah, it's good.
Okay. And recently, have you noticed any diarrhea, constipation, or change in weather preference?
No.
No. Okay. Have you recently had any injury to the head?
Not that I know, because I'm going to a lot of parties these days, and I don't know like what happens after that.
Okay. Can you tell me what you do at those parties?
I drink. I go out with lots of people.
Right.
I have lots of meaningless sex. So lots of things.
Sorry, I'm just going to have to stop you there.
And
Since you
no one
mentioned,
actually can control me.
okay. Sorry, since you mentioned drinking, how much do you drink, and do you binge? And since how long have you been drinking?
I don't even count, doctor. It's just like I feel like I need to drink a lot. If I could just drink like 5-6 bottles of wine at the time.
All right. Do you know if you suffer from any chronic medical illness, particularly have you been diagnosed with any previous mental illness?
No.
Or any family history of any of those?
No.
Okay. All right. Now I'm going to ask a little bit of questions that may sound strange, but these are screening questions. I have to ask all my patients these questions. Okay. So, do you feel, see, or hear things that other people don't?
No, actually not.
Okay. Do you feel that you have some special powers?
But not a special power like Harry Potter. But yes, I have some special things in me. As you can see, I'm going to get the Nobel Prize, and I have lots of things going on. And yeah, I feel like it's special, and that's the reason the counselor and
sorry, I'm just going to
university
cut you off
teachers are
again.
jealous of me.
Do you think that someone's putting thoughts into your head, taking thoughts into your head?
No.
Okay. Do you feel guilty or anything?
No.
Okay. Do you feel that your thoughts are being echoed?
No.
Broadcasted. Okay. Do you feel that people are always talking about you, or the radio or television is always talking about you?
No.
No. Okay. All right. Then now, do you think life is worth living?
Yeah, like if you had asked me 3 months ago, I would say, what's the point of life or everything? But right now I'm feeling, yes, the life is worth living.
Okay. And then have you had any passing thoughts of harming yourself or harming others?
No.
Okay. All right. Then have you had any previous attempts at harming yourself or harming others?
No.
Okay. All right. And you've told me that you used illicit drugs, correct?
I'm using a lot of drugs, doctor, these days.
And any known allergies?
No.
No. Okay. Other than that, any other concerns regarding your health?
No, I didn't think so.
Okay. All right. Thank you for the short history, Sarah. So if that's okay with you now, I can discuss what are the possible causes. So from what you've told me, I'm suspecting most likely what you are probably having is what we call a bipolar mood disorder. Okay. So basically it means that like often you'll have very, very high mood for a good majority of long period of time. And then sometimes you can have low mood as well. Okay. Now, usually clinical symptoms are that, you don't require much sleep, you feel really good, you feel energetic. These are what the clinical symptoms are. But again, other causes can present in a similar way, like, it could be any thyroid problem, which is a gland in the neck. So when it doesn't function, it can present with similar symptoms. It could be mania, which is just a sudden onset of, you feel energetic, you feel good. Okay. But again, less like in your case, because since you mentioned that you have had 1 or 2 episodes where you felt low. It could be depression, but again, very unlikely because they typically present with low mood. It could be due to any substance abuse or alcohol, which is something we still need to rule out, but we need to do further testing for those, okay? The other thing is it could be due to any head injury you might have had, okay? But then again, we have to maybe do a CT scan just to make sure that you haven't hurt your head. It could be an adjustment disorder or an anxiety disorder as well. Just like to confirm, have you recently changed universities by any chance?
No.
No, okay. So again, that makes any adjustment disorder less likely, okay? Any other questions so far, Sarah?
No, doctor. Thank you.
Okay.
I'm up.
Yeah.
All right. Dr. Wafi, you did really good, I would say, but one thing is very important. Do not interrupt your patient. Because I know like time is ticking and it feels like many of patients are like one of the most disturbing patient, I would say. So it will be disturbing in the exam, a lot more what I was, and you have to hear them. You have to give them one time, they will stop. But if they're talking like excessively,
Yeah.
then you interrupt them. But if they don't talk to you, how you will get your questions answered, right? Like in all this bubbling and lots of talking, the answers are in those things. So you have to listen to them, that what they're exactly trying to say. Everything they are trying to say, like there are some reasons why they are trying to say that. We're trying to help you with your diagnosis mainly.
Okay. So this
All
was
right,
a
now,
case
so
of bipolar or?
no, this was a mania case actually.
Okay.
So I can't remember, like I said, like I had a low. When you asked me low at times, what I say that, no, doctor, I feel all right most of the time, but for a couple of weeks, I'm feeling really good. Okay. I don't remember if I actually said low mood or not. If I said yes, it's fine to have a bipolar disorder. Okay. So most likely it's a mania case because all the other features, like obviously if you get that patient says, yes, doctor, sometimes I feel really low, then you can give it as a bipolar disorder. That's fine. But otherwise, if you don't get that, so it's a very, very important question actually, right? Like in that case, you will also get that patient had a previous history of depression. When you ask the past mental history or mental condition, they will give, yes, doctor, I had depression a couple of times. So then you know that, yes, this is a bipolar disorder case. But most likely, I said no other mental condition, depression. So in this case, we'll give our diagnosis as mania because if you look at the mania scenario, you will find out everything goes with this patient. What are those? So patient was talking excessively, loudly, and there was rapid pressured speech. This patient was feeling really good for a couple of weeks. And one thing that you should really ask, this one, it's in your stem. She hadn't slept in few days. You have to ask in detail about this one. So I got to know from the notes that you are not sleeping in few days. Can you describe a little bit for me what exactly it means? Do you have difficulty in sleeping or you don't feel like sleeping? Okay, so it's very important to ask these questions. Whatever given in your stem, always try to ask those questions promptly from the patient. Do not miss this thing because these are given already. Okay. All right. And then after that, so this sleeping is important to ask. Then what else you have got in terms of mania, that this patient was going to the party. So lots of impulsive activities. So increased sexual drive. So I say that, yes, doctor, I'm doing meaningless sex, meeting a lot of people. So those are impulsive act. And if you, now in this case, because it's only history, diagnosis, and differentials, we need to also ask some of the questions of mania. Now that's fine because we haven't discussed it with you guys yet. So we'll discuss it now, that what are the questions in terms of mania history. So apart from the psychosocial history that you have learned, you have to always add some things in terms of the questions, especially if they ask you diagnosis and differential and only history. It's not a MSE in here as a task. just a history and diagnosis. In that case, let's say this was a depression case. We have to ask MSE questionnaire to diagnose depression. Now, this is a mania case, so we have to ask DIC first to diagnose mania in here. So we'll go through that in a moment. So those questionnaire will be added in here apart from all the other psychosocial history. So you asked most of those, but the mania questionnaire were missing. That's fine. We will learn about it today. One thing that was missing is the heads. That means ask about like, who do you live with? Very important. Do you have enough support at home? Very important to find that out. Then do you work or only you study? Okay, any stress going on in your university? Very important to find out the stress at home, stress at universities. Then what else? SADMA. So I think you ask about smoking, alcohol, and also the drugs. Very important to ask those also because it could be just a drug-induced psychosis. We don't know that. So apart from that, you ask most of the important thing. You also try to rule out organic histories. That means head injury, infection, or thyroid disorders. So very good history, I would say. Okay. So in the diagnosis, you can give as a mania. If I say that I was low, then obviously you can give it as a bipolar disorder as a diagnosis. So whatever you find in the exam, give your diagnosis in that way. The
Do we have to give
differential
reasons as well? Like if we give a
it's a very good idea. Yeah, so it's a very good idea. If you have some time, then say what is mania and why you are thinking that. So always a good idea to give reasons, even though it's not a task. So you can say in here that most likely, according to your history, I suspect you are having a condition called acute mania. Do you know what it is? No, doctor. So acute mania is a psychiatric condition characterized by feeling very high or you feeling very high for a few weeks. And in that time period, you engaged yourself in lots of activities, especially goal-directed activities, to involve yourself with some impulsive behaviors. And most importantly, in most of the time, patients lose touch with their reality. This is an acute emergency case, Jenny. So I need to send you to the hospital immediately. So just stop there. And then it could be due to other reason as well. Like then you can give other differential. What could be the differential? If you give acute mania as your diagnosis, give bipolar disorder as your first differential. Then you give adjustment disorder, depression, schizophrenia, schizoaffective disorder, drug-induced psychosis. Okay, all those things you can give here. But if I remember that I told that, yes, if you asked me 3 months ago, I would say that what is the point of life, right? So that can suggest that I was feeling low that time. So if you say in that way, always give logic. So, but it's still at this time, we would give our diagnosis as acute mania because this patient is fulfilling the full criteria of mania. Okay. So you can give in that way that acute mania on the background of bipolar disorder. So, Dr. Ravi, if you want to interrupt patient's talk, what should I say? I would say do not interrupt a lot. You can interrupt in a time, like if a patient talks for 1 minute constantly, then obviously you have to interrupt. But in this mania case, initially patient will start talking loudly, as I say, and they will give you most of the information initially when you just enter into the room. Okay, and at that time, whenever you see some pauses, like patient have to take breath, right? Whenever patient is taking breath, then you just take that opportunity and you say, Sarah, I understand that there is a lot of things going on in your mind, but don't worry, I'm here to listen everything that you are having. So that's totally fine, but let me ask you a few questions and then we can talk in detail about why your counselor is concerned about you. So in that way, whenever patient is taking some breath, they have to take a breath, right? Because they can't talk constantly 1 minute. It's not possible. So whenever they give a little pause, then you interrupt and then you say. Okay, that's a very good way. In that way, you are not actually just stopping the patient in the middle. And that sounds a little rude to me. Like if I am talking and you are also talking, an examiner doesn't like that. No one actually like it. So let them finish. Whenever they take a little breath, then you actually send your voice. Okay, that's a good idea, I would say. In that case, in this case, diagnosis, if your history is very good, Dr. Rabia, if you give bipolar disorder based on the, like you have to give your logic, right? If you give an appropriate logic that this was exactly what I found, then sometimes examiner can pass you also. But in a normal way, like if this case is a mania, as I can see, if you give the diagnosis as depression, that's a fail. Okay, in the diagnosis, you will not get pass mark. Now, you don't need to go in detail about any of these things. If many a patient says a lot of things, you don't need to go in too much detail because you will get a lot of interruption by the patient in this case. So just go along with the questions one by one, try to find out these things. Do not go too much detail. Like if I say, if I'm having a lot of drugs today, don't go in detail. If you have time, then you can ask, like, when is the last time what you have taken some illicit drugs or recreational drugs? Do you remember what was the recreational drugs you have been taking? So if you have time, then you can ask those questions. Most of the time, many cases, you will not get any of this, like any chance of asking in detail because the patient talks a lot, okay? Now come to the dig first thing. In case of mania, we follow dig first as a mnemonic. What is this dig first I was talking about? So it means that we have to ask this question. So D for destructible, that means patient will be poorly focused. They jump from one idea to other. So sometimes this patient was talking about biophysics, sometimes was talking about swimming, online courses. So lots of things going on at the same time in their mind. Insomnia is a very important. This is not actually insomnia. I would say it's a decreased need for sleep. Okay, that's I. Then G for grandiosity. They will have inflated self-esteem. Like this patient was having. She thinks that the university professor doesn't know anything, counselor doesn't know anything, and she is going to get the Nobel Prize. So grandiosity is a very major finding. You have to get it here. Flight of ideas is F. So racing thoughts, as you can see, activities, they will have increased goal-directed activities. So they will engage themselves in a lot of activities at the same time. Speech will be rapid, pressured, and talkative and loud. Thoughtlessness. This thoughtlessness is mainly, they will be quite impulsive. Impulsive means they will involve with lots of risk-taking behaviors, which means they can have a lots of increased sexual drive. So as I said, like meaningless sexual intercourse with lots of people, that's one of the findings. Then reckless driving, spending a lot of money, doing a lot of gambling, okay? And also, let's say, investing in lots of business and then just getting bankrupt. So these are thoughtlessness or impulsive behavior. Very commonly, you will find out in a mania patient. So we'll ask for these questions if you don't get it. And they have increased energy, they have decreased need for sleeping, they have an inflated sense of self-esteem. So all these things, you want to find it out in your history. So when you ask it exactly, so you ask mood question, always with the mood question, ask about, do you feel low at any times? Then second, sleep. So in the sleep, you will get that decreased need for sleep. Appetite, you can ask. That time, before going to the suicidal ideation, you can just ask these questions. Because by that time you enter into the room, you already know this is a mania case. Okay, just by the patient's talking and everything, you will know what it is. So then you ask, like, do you feel increased energy these days? Yes, doctor. Then do you think that you have any special power? Okay. Are you spending a lot these days? Okay. Then you can say, are you having a lots of goal-directed activities? Are you having lots of thoughts in your mind? Yes, doctor. So those sort of things you have to ask from the patient. Especially we ask about energy, sleep, mood. We ask about sexual activity, spending. Okay, we ask about these things you don't need to ask, because you will see that patients are having racing of thought. Patients are quite destructible. You will see in when you are talking with the patient. So you don't need to ask those questions, but you ask about mood, sleep, you ask about energy, sexual drive, increased spending. So those questions you have to ask. And self-esteem, grandiosity behavior. We call it mania if this patient have these symptoms for at least a week, and that affects their social, functional, and occupational life. Then it becomes mania. If it is less than 7 days, and it doesn't affect their social, functional, occupational life, that's hypomania. Okay. And so what is the differential diagnosis? Now, differential diagnosis will be a lot, right? In this case, you can give bipolar disorder, you can give schizophrenia, drug-induced psychosis, schizoaffective disorder, substance abuse, adjustment disorder. Okay. So those will be your main differentials in this case. Here, guys, any question? Someone's microphone is on. I'll just mute you. Okay. You don't need to explain differential diagnosis, but you can say that why you are not feeling that it's a depression, why it's not bipolar, why it's not substance abuse. You can give it if you have some time at the end. Any question? All right, so let's move to the next one. Those who are in the Facebook, do you have any question? Let's see. Yes, Dr. Junaida, you can say that for the ulcer management. If patient is not too much bothered, and it's a psychiatric case, don't bother too much with the ulcer. Just ask it that how are you feeling, any pain in there, all these things. And that's very important, guys. As I say, that listening to the patient and do not interrupt in the middle. Okay, so that means that you need to show to the examiner that your approach is very good. Otherwise, they will not pass you. Approach is very important in psychiatry. And if you need to interrupt, like, be very, very, very gentle. Like, I can't say enough how much polite you have to say. Like, you have to go down to the art. Like, well, like, you have to show that you don't have anything to do but to interrupt this patient. But as I said, always take the time, see that what the patient is trying to say, and then when patient takes a little breath in between they're talking, then you interrupt. Yes, you should never use medical jargons with a patient. You can always say the term, Dr. Neetu, like you can say that, yes, it could be bipolar disorder, but because you don't have any previous history of depression, it's unlikely. In that way, you say that why you don't think this is the diagnosis. So the thing is, you can use medical jargon, but whatever medical jargon you use, you have to explain immediately. There is no exact number of differentials you have to give. Just give 4 or 5 differential diagnoses if that's a task. Now, That's a good question, Dr. Rabia. If you get a lot of finding, like if you already patient says that patient having lots of energies, patient having like increased activities, then you don't need to ask it. What you say, you just need to ask that. And when you give your reasoning at the end, then you just add those things that, well, I'm thinking that because you are having mania, because you have this finding, because you are going outside doing a lot of parties, you are having meaningless sexual drive, you're feeling very good for a few weeks, you are having increased goal-directed activities. So all these things put you to the diagnosis, most likely to be mania. So that's how you say your reasons. No, when you say diagnosis, you don't need to give management. No need at all. Cool. Let's move on. Who wants to do the next? I think Dr. Nargis was wanting to do that. And Dr. Shehar, I think, said first, right? So let's start with Dr. Shehar first. Now we'll do one case, which is video MSE. Okay. So Dr. Shehar, can you hear me?
Yes, sir, I can hear you.
Okay. So we'll do a video MSE with you now. And this one also. And for video MSE, the important part is that you don't miss anything. Okay.
Yes, sir. I'll try. I'm not good at it, but I'll try.
That's fine. You'll be fine. Don't worry. So now we are going to do a MSE video. In here, in the exam, what usually they ask you to do is that they will show you a video for 4 to 6 minutes. And usually it's more commonly comes in face-to-face exam rather than online. But in online also it's possible, because as you can see, I'm doing it with you, and that's exactly how they can also do. So in this case, if it's a face-to-face exam, there will be a kind of projector or something like that into the room where you can see the video. So the video will be played, and one of the examiner will be in the room also. So examiner will play the video, and usually after 6 minutes, they will stop it. Sometimes it's only 4 minutes, and then you get 4 minutes to deliver your MSc. It totally depends how they formulate, but you have to prepare both ways. So in the MSc video, whenever you go inside, always you talk with the examiner, you greet with the examiner, and then the examiner will always ask from you that, are you ready to hear to watch the video? What you can do at that time, just to write the aseptic J3R, you can just ask the examiner, dear examiner, would you excuse me for a few seconds? I would just write something in my note, and then will you be able to play the video for me, please? So in that way, it's a good approach. That way, if you become being frank with the examiner, they will not fail you, and even they will not do anything. They will be happy that you asked for it. Okay. Or if you feel shy, so then whenever the video is starting, you just very quickly write aseptic jet here in the paper in front of you, because in this case you have to find everything that you can see and that you can watch. So everything you have to write so that you don't miss anything. Okay, so write the positive findings in front of the aseptic jets here. All right, so Dr. Shear, the
Yes,
video
sir.
will be played for about 5 to 6 minutes. And
Yep.
once the video is off, you need to present the MSc to the examiner.
Okay, sir.
Okay, now for that, you don't need any 2 minutes outside. So we'll just start right now.
Hi Andy, do you want to come on in and have a seat? I'm Dr. Taylor, I'm the on-call psychiatrist for this afternoon. I got a call this morning from your family doctor because I think you went to see him this morning along with your mum, and I gather that things have been a little bit difficult for you. You've had some rather distressing experiences. So I think your doctor thought it might be helpful for us to have a bit of a discussion about that to see if I could help. Would that be all right with you?
No, it's fine.
Would it be all right, Andy, for you to tell me a little bit about what's been going on?
Well, you're going to think it sounds stupid, but my housemates are working for MI5.
Right.
And they're doing stuff to my brain.
Okay.
And they're out to get me.
Okay. That must be very difficult for you.
Okay.
How long has this been going on for, Andy?
About 2 months.
Right. And how did you first work out that this is what was happening?
I came home one time and they'd moved the TV to the other side of the room, and
Right.
I knew then
And what was it that you knew at that moment?
that that they were for MR5.
Right. Okay. Okay. So it's been going on a couple of months.
Yeah, this new lecturer started at uni,
Right.
and he works for MI5. And
Right.
he basically drafted my housemates in, turned them
Okay.
against me.
Okay. Okay. Now I've noticed a couple of times while we've been talking that you've sort of looked round you into the room as if you're checking for something. Could I ask you what's happening at those times?
Well, I can hear them talking about me.
Right. Who is it you can hear?
My housemates.
Right. So that you recognise it as their voices?
Yeah, I can hear them all the time.
Right. How many voices can you hear, Andy?
3. There's 3 of them.
Okay. And do they sound real, like my voice sounds talking to you now?
Yeah, it's odd. It's like I can hear them when they're not here.
Right.
And
So what they're not when they're not in the house with you?
yeah, it's like they're in the other room or something.
Okay. Okay. And can you hear what they're actually saying?
Yeah, they're talking about me.
Right. Okay.
They're always talking about me.
Okay.
They're always commenting on everything that I'm doing.
Right. Can you give me an example of what they would say?
Well, like if I'm packing my bag to go to uni or something,
Mm-hmm.
they'll comment on that, like he's
Right.
left the house now.
Okay. Okay.
Or, you know.
Anything else? Do they ever talk to each other, perhaps about you?
Yeah, that's what they do. I mean, and now they know. They've sort of twigged that I know about them now,
Right.
and they're saying like I'm making trouble,
Okay.
and that they're gonna sort me out.
Okay. Okay. What about actually talking directly to you in the way that I'm talking to you now? Does that ever happen, Andy?
No.
Okay. So you've been hearing the voices of your housemates. Have there been any other changes? Have there been any changes perhaps to the way you're thinking? Sometimes people tell us that their thinking changes in some way. So for example, they might feel that they're getting thoughts put into their head that aren't their own. Have you had any experiences like that?
Yeah, I do think things that aren't me. Like
Okay.
they're putting stuff in my brain. It's not me. I'm not thinking.
So different
that.
thoughts in your brain.
Yeah, that's
Right.
like it's stupid stuff as well. It's like the other day I suddenly just started thinking about some woman in Coronation Street. I don't watch any of that crap.
Right. It's not your kind of
It's
thing
not-
normally. Right.
They're not my thoughts.
Right. Okay. And do you have any idea how that's happening, or who's
this-
responsible?
It's MI5. It's this chip they've put in my head,
Right. Okay.
and I can feel it all the
Okay.
time.
Okay. So you're getting thoughts put into your brain that aren't your own. What about a different sort of experience? What about the experience that somehow other people are able to know what you're thinking, even though you haven't actually told them?
No.
Nothing like that.
They're just putting stuff in my head.
Just putting stuff. And can I just check, Andy, as well, that you're not getting the experience when your thoughts just stop altogether, like you have no thoughts left?
No. If anything, there's too much in there. I wish I
Right.
could unplug it.
Okay. Okay.
Just get this thing out of my head.
Right. And you mentioned this chip or this device in your brain. Do you want to tell me a bit more about that?
Well, it's a tracking device, so they
Right.
know where I am at all times,
Right.
and I can feel it moving around, like
Right.
rotating
So you can
around.
feel the physical sensation in your
Yeah.
brain. Okay. Okay. That must be very difficult for you.
I don't know why they're doing this to
Right.
me. I've done
Okay.
nothing wrong.
Okay. Can I just check, are there any problems, Andy, with the rest of your body? Any changes in sensation or any bits that feel different in any way?
No, feel fine. I'm not
Right.
I'm not ill or anything. I
Okay.
just want this thing on my head.
Okay.
All right, so now you will get 2 minutes to present the MSE. So just start the timing. So start, please.
Oh, do I start? Good morning, examiner. So according to the video, I see that the patient is very well groomed. He's sitting upright very nicely in the chair, but he's talking in a low voice. He constantly looks around the room and looks very anxious as thinking that there's someone in the room, and continuously talks about people, his housemates talking behind his back, and he says if they're not physically present, they could be in the other room as well. His eye contact is pretty good, although at times he does keep moving it to around the room. His speech is quite fluent, but at times it does become a bit mumbled when he seems a bit more anxious. And so his mood also looks anxious, and he looks he's not slouched back in the chair. Also, he talks about auditory hallucinations, so he keeps hearing voices and he thinks that they're very real. Regarding when he says that he hears his housemates talk about him behind his back and they're very real. He also mentions that thoughts are getting put into his, and he's having thoughts insertion into his head, which is put there like a chip in his head, which has everything in it. There is no thought withdrawn or thought broadcasting of any sort. He didn't talk about any delusions of grandiosity or he has any special powers or anything like that. As for insight and judgment, the questions were not asked about the insight and judgment. That's about it. Thank you.
All right. Anything about the risk and rapport?
Oh, as in between the doctor and the patient?
Yeah.
The doctor developed a very good rapport with the patient, and she developed, patient seemed actually moderate risk, as he was having a lot of auditory hallucinations and he was thinking that the housemates were going to harm him.
Okay. Good, Dr. Shehan. You did really good. But
Sorry, sir, it was so difficult. I've never done anything like this before.
yeah, I understand. Like, this is quite new, right? Like, I understand, like, for many of you, this should be like, well, what's this thing? So this was actually given, like, I think 2-3 years ago, the AMC started this video MSc presentations. And in one sense, it's really easy because you don't need to ask anything.
Sorry.
But the finding, like getting the findings can be real hard, because sometimes some of the accent in here can be really hard to get. And sometimes even like they talk very slow and sometimes very fast. So that's where is the challenge. So that's why it's very important to find out like what they're actually trying to say. Even though if you don't give the reasoning of every finding, that's fine, as long as you give the positive findings. That means you can't miss any positive findings here, because they know that in here the only marking you will be getting is from the MSc, right? Because you are not asking any questions. So the marking will be based solely on your 2-minute performance. So that should be absolutely perfect.
Yes,
so
sir.
that's the thing why a lot of candidates fail these sort of cages, because they don't, like in many cases they become flexible, but these cases they are very, very strict. So in this case, what we would say, like you I think you told most of the finding, but a couple of findings was missing. So in here we can say in this way that, well, we have got like you will get a stem that what is this present and why this patient is presenting to you. So let's say change in behavior is the presentation. So you can say, dear examiner, I'm going to present a mental status examination of my patient John, who is a 47-year-old patient coming for change in behavior recently. According to the appearance, I can see he's dressed well to the appropriate to the weather. He seems to be well groomed. He was maintaining eye contact at times, and sometimes he was not maintaining. He was responding to some internal stimuli because he was looking into different parts of the room on and off. He was not having any abnormal posture, and he was answering questions appropriately. His speech was normal in tone, volume, and rate. There was no disorganized speech or rapid pressured speech. The emotion was not assessed. Anything which is not assessed, just say in here that it's not assessed. Don't comment on that. Okay, so emotion was not assessed. In terms of perception, he's having auditory hallucination and tactile hallucination because he can hear the voices of his roommates, I think, or the neighbors. And also he feels like there is actual chips in his brain. So that question was asked later on in the video, that do you actually feel that the chips is in the brain? Then he says yes. That means he's having tactile hallucination also. Then you have thought form and thought content. So thought form was linear, no loosening of association, tangentiality, circumstantiality. Thought content, there was a lot of delusion in here. So first delusion was delusion of persecution or paranoid delusion, because he thinks MI5 is spying on him. Then the neighbors are commenting on him, right? Or the roommates are commenting of everything he's doing, and they are also talking about him. That is exactly what is delusion of reference. And also he's having thought insertion. But in here, they have assessed particularly that there is no thought withdrawal or thought block. If something is assessed particularly in the video, always give that finding that there was no thought withdrawal or thought block, as you said. Insight, cognition, judgment was not assessed. In terms of risk, this patient is moderate to high risk because having active hallucination and delusion. And then the examiner, or you can say the doctor, was able to maintain a good rapport with the patient, and the history doesn't seem to be reliable. So it's a good idea to take a collateral history from his roommate. So you don't say that I would like to take a collateral history from the roommates. You will say it's a good idea to take a collateral history from the roommates. So as a third person, you will do that. Okay, here?
Yep.
So
Yep.
that's pretty much everything in here. But you did really good for the first time, Dr. Sheher. I would say the way of your explanation is very good. So you will be fine, I know.
Okay, thank you, sir.
Thank you. Yeah, Dr. Maliha, like it's actually comparing the dress of the patient to the dress of the examiner. Okay, if both of them are wearing sweater or wearing something which shows that it might be cold, okay, so that's fine. So usually like they dress appropriately, but sometimes like many a patient can have like inappropriate dress. So always compare both, like always compare with the examiner and also with the patient in that way. Examiner, I mean the person who is interviewing. Yes, these video clips, now, no, not these video clips. They have their own video clips, which only they know what are those. So they have their own video clips, which can be given in your exam, similar like this. And Dr. Idris, you asked, are we providing differential to the examiner or patient? This will be appropriately written in your task, that who you should give differentials. Okay, everything is very well written. The tasks are very well written, that they will always write in that way. Explain your most likely diagnosis and differential diagnosis to the patient or to the examiner in that way. So you will know who you have to give the differentials. Yeah, risk, anyone having active hallucination and delusion, they are actually high risk. So if you say moderate to high, or even if you just say high, that's fine. Yes, the Dr. Kura, cases are very typical. Usual cases for MSE video are mania, schizophrenia like this one, sometimes depression, and one I can think about OCD. Okay, these are like all the typical cases. Remember, typical cases are not that typical in the exam. Okay, so you have to be very good. Even though like you know everything, sometimes during the exam pressure, you can forget the things which you can easily see. Like see that the previous case that Dr. I think, who did that? Dr. Wafi did that. It was written that the patient was not sleeping very well. So it's because of the pressure, even we don't even look into that. And that's very commonly happen. But we know these things, right? That happens in the exam, like more than what happens here. And that's why doing a lot of role play makes you more confident. Yes, you have to actually, Dr. Misbah. So you have to take, when you watch video, you have to take notes. Otherwise, you will not get any extra time for writing. And it's very important to write whatever you are getting. Just write the positive findings. Like when you get delusion of persecution, just write D dot persecution so that you understand what you have written. They will not like read your notes in here. So just write what you can understand. And depending on that, you can just present your MSc. And Dr. I don't know who asked this question, AM. So for the previous case, do I explain each diagnosis to the patient or I just list them done and only? It totally depends on your time. If you have time, it's always good to explain how you ruled out your differential diagnosis. Okay, it's very, very good approach. Once we move into like the medicine cases, you will know how to talk about these differential diagnosis things. Okay, in case of psychiatry, usually we don't get too much time to explain differential diagnosis. So in the exam, you will not get that much time. But in other cases like medicine, we will get time and we have to explain in a very specific way. In the next class, we will start with cardiology. You will see how to give differential diagnosis with reasons. Cool. We have only one case we will do tonight. I think we can finish it with that case. So Dr. Nargis, you wanted to do that, I think. Yes, it's very much okay, Dr. Rabia, that if you finish a station before time, it's very much okay. So they ask you, like in face-to-face, they ask you that, do you want to finish your station or do you want to go outside? So if you finish your station before time finishes, you can stay with the patient or you can even go out of the room and then just wait for the next station. That's fine. Same with the online exam also. You can go out or stay with the patient. So who wants to do? Dr. Nargis, are you here? You want to do the role play now? No, it's not always fixed. It's not always fixed for explanation. Okay, Dr. Nito. So it depends on what is your task. In the task, if it is written that take history for no more than 6 minutes, that means within 6 minutes, you have to finish it. If you finish it early, then you go to the management. Okay, so we'll finish with Dr. Nargis today. Let me unmute you, Dr. Nargis.
Hello.
Yeah. Okay.
Hi, doctor.
Just
How are
give me
you?
1 minute.
Okay.
I'm fine, thank you. Sorry, I should ask you that.
No,
All
no
right.
problem at all.
So,
I'm not very good in psychiatry, but I'll try.
it's fine. If we don't try, how will we learn, right?
Yes.
Just a second. Okay. So this is your case.
It's-
What happened? Just a second, I think. Okay, this one. So we'll start in 1 minute time. This patient name is Jenny. Okay. All right. So this is just one second. Okay. So this patient name is Jenny. You can start.
Okay. Hi, Jenny. This is Nargis, one of the doctor here. From the note, I got to know that you are having some sleep issue. I am really sorry to hear
Yes.
about that, but I'll try my best to manage your condition. So can you, may I know what exactly going through?
Yeah, doctor. I'm having these sleeping problems for a long time, and my GP started with this temazepam, and it actually helped me for the last 1 year to sleep. So if you can just give it to me, and then I will be good to go.
Oh, okay, I'll not take much time so that I can help you better way. I'd like to just ask you a question, but before that, let me assure you, whatever you discuss here will be strictly confidential unless it is harmful for anyone. Is that okay with you?
Yeah.
Okay, so Jenny, may I know exactly what problem you are having, like sleep problem? Is it difficult to fall into sleep, or did you wake up multiple times, any nightmare? What exactly happening?
No, actually, I'm actually waking up very early in the morning.
Oh, okay, I understand. So last 1 year, you are having this problem. So may I know who prescribed this medication for you?
The one of the GP, I was in another state before, and he gave me the temazepam, and I also used to get it from some other GPs.
Okay, I understand. So how many tablet you are taking in a day? May I know?
1 tablet.
Okay. So by any chance, did you got any side effect?
Not really, but it really helps me to sleep at night.
Okay. So did you ever try to go without sleeping pill? So how you, do you feel at that time if you skip the this sleeping pill?
Actually, I can't sleep without it, but I don't feel any other problem.
Okay. So do you recently increase the dose by any chance?
No, I've been using just one tablet for the past year.
Oh, okay, I understand. Okay. So so Jenny, may I know how is your mood these days?
Uh, I don't feel good. To be honest, I feel very low and sad.
Mhm. So have you ever felt high mood anytime?
No,
Okay. So apart from sleeping problem, did you notice any weight loss, appetite loss?
yeah, just don't feel like eating. And yeah, obviously I'm losing weight.
Okay. So did you ever try to harm yourself or other?
I don't, but sometimes when I wake up in the morning, I just feel like, what's the point of living? There is no point.
Okay, I'm really sorry you are feeling like this to hear about that. So by any chance, did you feel guilt for any reason?
No,
Okay. So what about your like, did you ever, have you ever, like, can you concentrate on your daily activities?
no, Rian, I can't actually. That's why I had to lose my job also.
Mhm. So do you enjoy the thing that you are used to enjoy before?
Not really. I just stay at my home.
Okay, I understand. So Jenny, I am going to ask you some screening question, but please don't feel embarrassed because these are the routine question we need to ask your question to your patient. So did you, can you hear, see or things when no one is there?
No,
Okay. So, okay. So do you think someone is trying to harm you or someone is spying on you?
no.
Okay. Okay. So, so do you think you need any help from our side?
Yeah, I just need this sleeping pill.
Okay, understand. Suppose if this room catches fire, what would you do?
I would try to escape.
Okay. Okay, I understand. So, Jenny, do you know who I am?
Yeah, you're a doctor.
Okay, where are you at the moment? Where are you at the moment?
In your GP practice.
Okay. So I understand you are taking temazepam for 1 year. Apart from this, are you taking any other medication?
No,
Oh, okay. Are you generally anxious person?
no.
Any stress going through in your life by any chance?
What can I say? It's just about my parents.
Mhm.
They just can't understand what I want. They have a very high expectation from me, and I can't share anything with them. So it's just like I'm alone, but it's still I'm having my parents with me, but they're so strict, and I don't know like how to deal with that anymore.
Okay, I understand. So try not to worry. I'll try my best to help you in all possible means. So Jenny, are you doing study or doing any job?
I'm doing part-time study, but I don't feel like going to the universities or anything. And I just said I lost my job also.
Oh, okay, I'm really sorry to hear about that. So Jenny, do you smoke?
Sometimes, yes.
Okay, so how many stick and how long?
I've been smoking for like 5 years, and usually I smoke out five cigarettes a day.
Okay, if you agree, I can arrange another consultation to discuss about it. Is that okay with you?
Yeah, sure.
So what about your drinking?
Just occasionally.
By any chance, any illicit drug, any over-the-counter medication? Have you tried?
No,
Okay. Okay. By any chance, have you injured in your head?
no,
Any recent changes in your weather preference?
no,
Okay. By any chance, any recent history of any fever, any infection or flu-like illness?
no.
Okay. Mm, Okay, any recent changes in your home situation?
Not really.
Okay, so have you ever tried to avoid public place?
No.
Any chest pain, any shortness of breath by any chance?
No.
Okay. So thank you, Jenny, for information.
This time is up. So
Okay.
why you don't linger the history? That's the thing. Like you already finished about a minute ago, and don't. That's a common thing that happen in our head. That will have I missed something? If you think that if you can't find out the questions in your head, that means you did not miss anything. So just finish it and just finish the diagnosis and differential at that time. So do not prolong the history, because the last questions that you asked for the 1 minute, it was not very important. You asked all the important things. The history was perfect, I would say. Okay, so Dr. Nargis, initially you told that you don't have a very good psychiatric knowledge, but I guess that you are having a very good approach. Okay, so your approach was perfect, I would say. That means whenever I say that when I said something really sad, you immediately your approach was very good. That you say that yes, I'm really sorry, and don't worry, I will help you. So that's what they want from you. Okay, so even if you don't know a lot of things, your approach is good. See that you will pass the exam. Okay, recently a couple of our students who passed, they passed globally. Like global score was passed, but their key step was missing, but still they passed because of their approach. So we teach that approach to the candidates, and they really follow those sort of things, and it's really help. So approach is very, very good. So one thing that Dr. Nargis that you need to do, that don't prolong your history. When you finish your history, thank the patient and then just give the diagnosis and differentials. What's your diagnosis in this case?
Actually is it's a dependency case, but yeah, she's dependent on the this medication, temazepam.
Okay, so is it only temazepam dependence or anything else, do you think?
Yeah, it could be due to like my differential diagnosis could be depression, and could be adjustment disorder, and could be substance abuse.
There.
Yeah,
that's fine. Now stop there. The diagnosis in here is not temazepam dependence. Why? Because see that when you initially you tried to rule that out, and you ruled that out actually with your questions. That means you asked me that how many tablets I'm using? 1. Have I increased it? No. So usually dependent patient, they have tolerance. Initially they start with 1, then they have to increase their dose like 2-3 drugs at a time. So I haven't done such thing. Then I told that, well, if I stop temazepam, do I have any symptoms? I don't get any withdrawal symptom, just I can't sleep. And that's not withdrawal symptom. If I have withdrawal symptom, I would feel anxious, irritable, or all those sort of things, right?
Yeah.
So this patient, this is actually a confusing, like just to confuse you, this was given in the STEM. And there is a case of temazepam dependence also, but in that case, you will get all the findings like, yes, I started using the temazepam, and then I have to increase it. I take like 3-4 tablets in a day. And if I don't take it, then I get all the withdrawal symptoms. So usually, if you want to say it's a temazepam or any benzo dependence, you have to find those findings. One, that they need to increase their dose. The most important thing to say that patient is dependent on it, that if they stop it, do they get withdrawal symptom? Okay, so that's very important. If they don't get withdrawal symptom, they haven't developed tolerance, just only 1 pill for every year, it's not temazepam dependence. Okay, and on the top of that, on the top of that, you have got all the psychiatrics to diagnose depression in this case, right? So what have you have got? So this patient say that she's feeling low and sad. So mood you have got. S for sleeping. So obviously I'm having sleeping problem. Then I for loss of interest. So I have also lost interest. G for guilt. I don't have any guilt, so you can rule that out. E for energy. So you could ask that, do you feel lack of energy, fatigued, tired these days? That should be yes. C for concentration. You asked, I have loss of concentration. So M, Psych, caps. A for loss of appetite. It would be present in here. P for psychomotor retardation or agitation. So if you ask me, do you think you have become very slowed these days? I would say yes, doctor. I'm very slowed in every activities. So that's psychomotor retardation. And most importantly, suicidal ideation, that was also present in here, right? I told that sometimes when I wake up in the morning, I feel like, what's the point of life? And that's suicidal thoughts, actually. Okay, so in cases, when you get features of depression, ask all the MSE questions along with the psychosocial history. Just like the mania case we have done today is the same thing in here. So that's fine. We haven't discussed that in our last class, but today, right now, you know about it. So you will ask all these questions if you get a depression case. Okay, to diagnose it as a major depressive disorder, if at least 5 of these symptoms are present for at least 2 weeks, then you can diagnose it as a major depressive disorder. Okay, so the diagnosis is always major depressive disorder. Sometimes severity you can add. Okay, you can say low to moderate depression, or you can say severe depression. That's fine. I would say don't bother with too much like detail. Okay, you just miss important thing when you give lots of detail. So if you just give your diagnosis as major depressive disorder, and you can give reasoning that why you think so, like you have all these symptoms, that's why I'm thinking you're having major depressive disorder. That's fine. Okay, and then you give all other differentials. So in this case, the differentials will be, first of all, you can give adjustment disorder, you can give bipolar disorder, you can give drug-induced psychosis, schizophrenia. Those things will be at the end. Better, in case of depression, we put mainly major depressive disorder, adjustment disorder, then you can put on acute stress disorder or post-traumatic stress disorder. Then you can put generalized anxiety disorder. Okay, these will be your more appropriate differentials. Then obviously bipolar disorder, schizophrenia, that will be at the end. Very unlikely to be schizophrenia in this patient. So as a differential, you can give it, but not even at the first few differential. At the end, you can give schizoaffective disorder. There is no criteria for severity of MDD. As I said, do not go for severity. They don't ask you that is it like defined as a severity. So just give major depressive disorder. Okay, if they fulfill the criteria, then you give it in that way. That's why it's also important to get what is the duration of these symptoms. Okay, so ask them like how long you are feeling this way. Because to fulfill the criteria, you need at least 2 weeks. Okay, cool. Any questions? So Dr. Salman, if I need to repeat the mnemonics, then M for low mood. I think we have it in here. Oh, sorry, it's not here. So M for low mood, S for sleeping problem like insomnia, I for loss of interest, G for feeling guilty and worthlessness or hopelessness, E for lack of energy, C for loss of concentration, A for change in appetite, P for psychomotor agitation or retardation, and S for suicidal ideation. Yes, hypothyroidism would be a very good differential. So always we also rule out this organic differential, right? So hypothyroidism will be a very good organic DD in here. That's a very good question, Dr. I don't know, what's your full name, Dr. AM? So that's a good question to rule out adjustment disorder. Like anything particularly happened before you started this temazepam. Now, if it's for 1 year, it's very unlikely to be adjustment disorder, because the criteria of adjustment disorder means that this thing should not persist for more than 3 months. And Dr. Shobik, yes, doctor shopping to get medication. Usually we don't need to ask it to the patient. If we suspect someone to have this dependency, then we call to the doctor shopping people, and then we can find it out. But for this case, it's not needed. Cool. So that's pretty much everything in here. How do I, very good. How do I ask psychomotor? So usually just ask, because most of the patients with depression, they have psychomotor retardation, not agitation. So ask that, do you, usually they become very slow on their day-to-day activities. So you say that, have you been slowed down recently? Or do you think that you are very slow on your day-to-day activities? So the main thing is you need to find out that, have they become slowed in every activities they are doing? Coffee is not very important. You can ask it, but not so much important in this case. All right, so let me show you one thing for those of you who will be in our team will start to add you to the software, and you will get all the notes from here. And then I want you guys to start doing role play, starting from these notes. These notes will be there, and the name will be Psychiatry Role Play. Okay, so when you open it in the software, you will get all the questions and also a little bit of the feedback. That means the positive findings. Read it in your own time, and it's not the, remember, it's not the answer, it's not the approach that I have showed you. It's just some of the findings in here given. You will just read it to do the role play with your partner. Okay, so when you will start it, so there is a lot of questions for your practice. So practice that with your partner, give them findings, and then give them feedback that these are the things I was trying to give it to you, and you found these things and you missed these things. So open this note. It has, like, I can say, like a lot of questions and answers. So just go through that in your own time and do the practice. Okay, so lots of questions, lots of feedbacks and everything. So please go through that in your own time. Okay. So it will be in your software in the sample question part. Okay. And the schedule of the classes has been already given in lots of Facebook group, I think. So you will be getting it in your first aid AMC clinical group. If you just go through it, if you scroll it, you should be able to get it. I think the next class, when is the next class, guys? I always forget these times. 25th. So 25th will be your next class, same time. And Dr. Neetu, just send me a message in our messenger group, and then we can discuss about your problem. That's fine. To join the course, yes, you message me on the messenger, or you can even send an email to our outlook.com. I will just write the email in here. It's firstaidamc4536@outlook.com. If you send email or message, then we can give you all the details that you want. Okay, so that's pretty much everything on our today's session. I guess that you guys liked the class, and this is exactly how we usually take classes. We do one special things, like the MSE is very important for the exam, so that's why we do role play on a particular class just to cover these role plays. So just like that, we finish cardiology in 2 classes, and then we'll do a cardiology role play. There will be one random role play session, which for you guys, it will be a little difficult because random role play session, it takes questions from everywhere. Just the important cases, usually it's done by another doctor. So she will be also with you on 31st of August. Okay, and also I will start the session, that's fine. But random role play session, don't bother with that initially because it's new for you. We'll just do that randomly, some random questions. Okay, just to improve your role play. That's fine. But apart from that, we also do the subjective role play after each of the subject we finish. Like cardiology we finish, we do a cardiology role play. We do a psychiatry MSc, and then we do a psychiatry MSc role play. This is more better for beginners like you. And the random role play sessions, it's actually kept there for people who are appearing the exam very near. Like in this year, if someone wants to appear, those random role play sessions are very important for them. So the materials will be accessible only in the software. Usually our team is going to start to add you to the software. It usually takes this 2 weeks time to add everyone in the software because it takes a little bit of time and everything to give you all the access. So once this 2 weeks is finished, then you will be added to the software, everyone. Okay, those who enrolled. There is no only role play course. The role play course is only, this random role play session is only for people who are enrolled in our 5 months course. There is no other course. Yes, obviously you will get an invoice. You can obviously ask for it, that's fine. And you can use usually when you pay using the link that we provide, there is one of the printing page will appear in your site. You can always print that out as an invoice. For the moment, there is no PSYCHIATRY course, unfortunately. Okay, all right. So guys, do you guys who are in the Facebook, I think some of you asked some questions. That's why it's good to come in the Zoom. Then I can easily answer your questions if you come in the Zoom. Yes, Dr. Taiba, if the patient doesn't have suicidal history, you can say mild to moderate, that's fine. Don't bother with this severity, I would say. Just give a diagnosis of major depressive disorder, that's fine. Any other question you guys are having? So for all of you in the Facebook Live, I will go through your questions later on when we finish it. So write your questions in the comment box. Anything I have missed, I will answer you after I finish this one. Okay. All right. So the next class is on 25th of August. You can get all the schedule is already given in the Facebook group. So just go through the Facebook page and you should be able to find it out. Okay. Thank you, everyone. Have a good night. And we will see you in the next class. And the recording of this class will be given tomorrow or tonight, maybe tomorrow in the morning. Thank you all.